This is Lauren Sand, and I will be discussing our chapter, The Use and Misuse of Antibiotics in Neurosurgery, by Lauren Sand, Kristen Jones, Matthew Hunt, and Stephen Haynes. The objectives of this chapter are to understand the basic principles of antibiotic selection and usage in neurosurgery, recognize the risks including side effects, drug-drug interactions, and toxicities associated with each respective antibiotic, and develop a clearly defined methodology to antibiotic administration with the tools you have learned in this chapter today. To begin, I would first like to discuss a few common myths and misuses of antibiotics in neurosurgery. First, the notion that chloramphenicol, previously known as chlornitromycin, must be delivered intraventricularly. This is false, as this antibiotic penetrates the blood-brain barrier very well. Also, chloramphenicol requires hydrolysis in the liver to be active, and so if it is delivered intrathecally or intraventricularly, it will not be effective. Second is the misuse of vancomycin for what many neurosurgeons describe as surgical prophylaxis. This is inappropriate for several reasons. Vancomycin is often used to treat MRSA. However, surgical infections are not often caused by methicillin-resistant Staphylococcus aureus. Furthermore, vancomycin penetration into the spinal fluid in the absence of inflammation is especially poor. Therefore, use of vancomycin for prophylaxis in a non-infected patient is of little benefit, especially when placing it intrathecally. Overall, then, use of vancomycin for a broad prophylactic indication can lead to systemic toxicity in the patient and possible emergence of vancomycin resistance, which could lead to a global health issue when vancomycin is truly needed for an infection. Next, to re-emphasize a comment just made regarding use of vancomycin in an uninfected patient, it is false to assume that good CNS penetration of an antibiotic in the presence of meningeal inflammation is equivalent to its CNS penetration in the absence of inflammation. Factors such as inflammation, as well as lipophilicity and influx transporters, can actually increase the permeability of antibiotics. Antibiotics can cross the CSF or brain parenchyma more readily at the initiation of treatment, while the CNS is very inflamed. But then it is important to remember that as infection abates, the inflammatory response will also abate, and therefore the antibiotic dosage or selection may need to be readdressed. Finally, two colloquial phrases used in neurosurgery regarding antibiotics include "it can't hurt" and "more is better." The first phrase can be easily disbanded by referring to tables 55.1 and 55.2 in the next slides, which describe several neurotoxic side effects and drug-drug interactions of commonly used antibiotics. When thinking more is better, we should all be reminded of their neurotoxicities and drug-drug interactions, and also of the superinfections such as C. diff and emergence of drug-resistant organisms that can hurt our patients. Again, as described in the previous slide, Table 55.1 illustrates the related toxicities of several commonly used antibiotics in neurosurgery. As you can see, many antibiotics can cause seizures and other life-threatening neurological injuries. It is important, though, to keep in mind that even the most trivial side effect, such as GI upset, can be incredibly life-altering for our patients. Table 55.2 discusses the potential drug-drug interactions between commonly used antibiotics. In Table 55.3, we discuss wound classification of surgical site infections. An understanding of these categories allows for better antibiotic selection, both when deciding to use prophylactic antibiotics and when deciding how to best treat an infection. As stated prior, a more inflamed meningeal response will allow for greater blood-brain barrier penetration. And so, in conclusion, there are a few basic principles of antibiotic administration. 1. Antibiotics should be used only for the prevention or treatment of susceptible infections. 2. The choice of antibiotics should be guided by the most likely infecting organism and directed by culture results whenever possible. 3. Antibiotics should be used for their shortest effective duration. 4. The risks associated with an antibiotic administration must be considered every time they are used. 5. Dose and frequency of administration should be guided by principles of pharmacokinetics and, in serious infections, measured antibiotic levels.